Good morning. Welcome, and thank you for attending today's FASD Learning Series. Our theme for this year is prevention, and we have a promising lineup ahead of us, On September 26th, we opened the season with Nancy Poole, who challenged us to think about what we know about prevention and whether we're actually doing it. Today, Kirsty Prasad will present the first of 3 consecutive sessions about working effectively with women who use substances. Today's session is titled Values and Addictions. Before I introduce our presenter, there are a few housekeeping tips. You can ask questions during the presentation by using the question and answer module on the right-hand side of your screen. A session facilitator is monitoring the questions and will pose them at suitable times during the presentation. If we aren't able to answer all the questions during the live presentation, we will answer them via email after the session is over. It is important that you include your email address when you ask a question, otherwise we'll have no way to answer. The presenter's contact information can be found at the back of your handouts on the final slide of the presentation. In order to receive your certificate of attendance, you must have signed in after 8:50 a.m. Evaluations for the session will be emailed to you after the session. Please fill them out and return them. We really do rely on your feedback to continually improve what we do and how we do it. So we really appreciate that. Today's presentations and handouts will be posted for viewing and downloading on the CMC website. I'm going to give you that website address now. It's fasd-cmc.alberta.ca. If you experience technical issues, please email Clayton at, now I'm going to give you that email address, Clayton, Clayton, .Knoll, Knoll, at teacherstv.ca. Teachers TV is all one word, lowercase, .ca. Please let your local tech support know, as the problem may originate at your end. All right, that's the housekeeping. As Alberta advances with the FASD 10-year strategic plan, education and training continues to play a key role. This is our 5th year of offering sessions and our 2nd year of delivering the materials as webinars. As always, sessions are taped and made available on the CMC website at fasd.cmc.alberta.ca, in case you didn't get it the first time. We are pleased with the ongoing interest and attendance in this initiative. We appreciate the work of CASA, Child, Adolescent and Family Mental Health, and the Alberta Centre for Child, Family and Community Research in making this initiative such a big success. Now I have the pleasure of introducing our speaker, Kirsty Prasad, for this morning. Kirsty has worked with Alberta Health Services Enhanced Services for Women since 2002, where she works with women who use substances. In recent years, Kirsty has been training other service providers in the strategies and techniques that she and her Alberta Health Service colleagues have developed. Prior to coming to Alberta Health Services, Kirsty worked for Streetworks and the mental health unit in the inner city. And I keep calling you Kirsty. Is it Kirsty or Christy? Kirsty. Sorry about that. It's Kirsty Prasad. Kirsty has strong knowledge and passion for working with marginalized populations with substance use concerns. We're fortunate that she's going to share her wisdom and experience with us for the next 3 learning series. Please join me in welcoming Kirsty Prasad.
Good morning, everyone. And so just to let you guys know that this is session number 2. And the previous one we did was on values and attitudes. Today we're going to talk about what's actually unique about women in substance use. But if you hadn't participated in the first session, I'll just give you a little bit of background about the program that I work in. The program I work in is called Enhanced Services for Women. We've been around since 2002. Originally we were funded by Early Childhood Development. It was an FASD prevention program. And at that time we were connected to ADAC. And once we integrated with Alberta Health Services, we've been working with women that have more complex issues, who face multiple barriers. One of our priorities is pregnancy, but we work with women of all childbearing years, so which is quite large for the work that we do in regards to the population that we work with. And so We provide an enhanced level of support so we can go out into the community. We do outreach services as well as we meet with them on site just because we know best practices, that we work with women within our services and they have that continuity and stability of one counselor. And so that's kind of a really quick rundown in regards to the program I work in. The first session that we talked about was values and attitudes, and so what we're going to do now is discuss some of the issues related to women's substance use, and throughout the next couple of hours, definitely be open to questions as well, and having that. So the first slide we're going to talk about is what's unique about women and their substance use. When we did the myths and facts, we kind of did a teaser in regards to what is unique about what women face who are using substances, and so what we look at is her experience of health, her feelings of guilt, stigma, and shame, her experience of violence, co-occurring mental health concerns, women as mothers. In regards to that, just in regards to society and how we view mothers, and even within our own systems, sometimes we put a little bit more pressure, or there's a lot more stigma related to women who are using substances. And so it's really important to recognize how that can impact them, also impact their guilt and shame. And misinformation and denial among those in position to help. There's a lot of misinformation out there in the community in regards to pregnancy, the effects, and what is unique about women and their substance use. So before going into some more of the specific issues related, I asked the question, does gender matter? In your practice, wherever you're working, whether you work with women one-to-one, if you do outreach, if you provide groups, if you provide intensive programming, whatever that looks like, do you ever take into consideration, does gender matter when you're working with them? Because sometimes, particularly in the addiction treatment world, when you look at traditional theories, what has happened is a lot of the times we've kind of clumped men and women together and felt maybe the programs can work for both of them. And the more that we do research and the more information that we see that we can't apply the information to men and women because we are very unique. One of the things in regards to the traditional theories of addiction is, sometimes we have to break through that grandiose sense of self. Sometimes you'll hear people call themselves like king baby or queen baby, the macho self, and you have to break through that, and only then can you truly get into recovery. But for women, we already have a diminished sense of self, and so if we're kind of trying to beat through that and break through that, we're actually could be causing them more harm. And so that's why sometimes some of the traditional theories aren't always effective. Another area that we talk about in regards to gender is just looking at gender in general throughout the ages, even when medication, before I go into the slide really quick, even when we looked at medication and how it was prescribed for women. And, we hear the term hysteria, histrionics, some of the advertisements. It was actually illegal to show women in ads of alcohol for quite a long time. If medication was prescribed for women, back in the day it was cocaine, it was heroin, it was different kind of medications to combat our emotional issues. And so even within society over time, we've had a certain view of women, and even within our advertisements. And so this one's an ad on, I think this was in the 1950s, and it says, "Please, Dave, don't let me be locked out from love from you." And what it says here also is, often a wife fails to realize that doubts due to one intimate neglect shut her out from a happy married life. And this is an ad for douche. It's a Lysol ad. And what it's saying is women are inherently dirty, and only if we are clean can we really truly have a happy, healthy relationship. And that is very powerful, that message in itself. And the next slide is the Good Wife's Guide. This one was in 1955. It's from the Housekeeping Monthly. On it says women have to make sure that when their husbands come home, that they have to present themselves. They have to dress appropriately, have dinner on the table. When he comes in, make sure you greet him, ask him how his day was. Do not tell him about your day, because your problems don't matter. And it actually says that in here. Some of the other things it says is let's see here. Arrange his pillow and offer to take off his shoes. Speak in a low, soothing, and pleasant voice. Don't greet him with complaints or problems. Gather up the school books, toys, papers, etc. Make sure everything's clean. Prepare the children and make sure that they're quiet as well, because he's had a hard day and only his problems matter and yours and the children's do not, which again is very, very powerful. And even though this is in 1955, that's not that long ago, and a lot of these messages are still present today. And so it's really important to be cognizant of how powerful even these messages are. We may not see it as forcefully as this ad, but we'll see it in different ads, particularly around drinking. It's much more common to see a lot more drinking ads for women, directed at women, particularly our young women. There's a lot more binge drinking with our youth, young girls in junior high and high school. And so I think it's important to recognize the power of that. And so what I just say is, if you haven't taken into consideration some of the gender issues related to women and their substance use, one of the things what you could do, and it would be important to do, is just kind of reflecting on, okay, what do I do within my one-to-ones? What do I do in my group settings or even my psychoeducational settings? How do I make my program unique and be able to put in all the different areas that are unique and impact women that are different from men? I'm going to talk a little bit about theory before we move along, because I think it's important that it's like building the skeleton, and you have to have a foundation and a theoretical background, and then you can look at, okay, what are some of the practical strategies I can work with them? And so I look at it in 3 ways. Having a really strong understanding of addiction. I find in the work that I do, people do understand substance use. They understand the stages of change. They understand how it can be very cyclical. But one of the areas I find people get most frustrated when I'm working with different service providers is the relapse, and maybe not always understanding the relapse part of the addiction. And so really, truly understanding addiction and how that impacts people. Having a holistic health model. When I did the values and attitudes and we went through some of the myths and facts, we touched on the significant issue for women around their health. And so really having a strong holistic health model is very important. Having a woman-centered approach. Number 2 is theory of women's psychological development. And what is important in regards to that around the relational model, I'll touch on in the next slide, and then I'll talk about the theory of trauma a little bit in our 3rd session. That's going to be in December. I'll explain the theory of trauma and addictions in a much more deeper level, but just to kind of tease it right now, just to let you know that we also have to consider the trauma part for women, because there's such a high correlation between addiction and trauma for women. So traditional theories of psychological development for men and women. Traditional theories talk about to have a happy, healthy life and be able to have an intimate relationship as an adult. Through human development, we have to segregate and become autonomous from our parents. So you'll see that separation and that independence from teenage up to adulthood, and only then can you truly have a happy, healthy relationship in adulthood. What the relational theory from the Stone Center in the States talks about is women are much more relationship-based. Even in our treatment centers, they'll talk about don't focus on your partner, don't talk about your children, you really need to focus on yourself. And sometimes women are contracted, and they're told, okay, if you talk about the other people in your life, you may need to leave and come back when you're ready to focus on yourself. But it kind of does a bit of a disservice for the traditional development for women, because women are much more relationship-based. We see ourselves in the relation of other people, and so it's not uncommon for women to ask, am I a good mother? Am I a good partner? You ask them what their strengths are, they'll say, I'm a great mother, I'm a great partner. And so they always see their self-esteem as well as their connections in life through the relationship. So it's really, really important to validate and recognize the connections that we have. Some of the other areas that are very important, I touched on just briefly already, around the body and the health outcomes. Women have much more significant impacts on their life based on their health when they're using other drugs as well as alcohol. And so, for example, there's an enzyme that men have in their stomach that breaks down a chunk of the alcohol before it hits the rest of their system. It's about 30 to 40%. For women, it's about 3%. So the alcohol will break down about 3% to 4% before it hits the rest of our system. And so when we're drinking or using other substances, it goes straight to our organs, and it's quite much more potent than men. If you have a man and a woman drinking the same amount of alcohol, her blood alcohol concentration will always be higher for longer, because it just takes so much longer for her to actually metabolize that. And so that shows the significant impacts that alcohol and other drugs can have on the body. And so cirrhosis of the liver, heart disease, we're very high risk for multiple cancers. Korsakoff's Wernicke's, so that's the wet brain, the brain damage from the alcohol. It's not uncommon to have women that are in their 20s having strokes, heart attacks, and like I said, the Korsakoff's or Wernicke's from their alcohol use. And their menstrual cycles, that's the other piece, are greatly impacted when they're using. And so it's really important to recognize, when I talked about in the myths and facts, and I said, is FASD 100% preventable? And it's kind of a trick question, because a lot of pregnancies aren't planned. Women don't have recognition of pregnancy until 6 weeks to 8 weeks, something like that. However, if you have women that are using, and if they don't have a regular cycle, I have had women that have not had a cycle in like 2 years, or they'll go 6 months, and it's just never regular. And so it's not uncommon for them to actually have recognition of pregnancy until second or even third trimester of pregnancy. And so that's another piece that a lot of the women that we work with face. And so when I talked about having that integrated approach and having a holistic health model, the importance of having them connected to healthcare, just because the amount of damage that the substances can play on them. For men, they can drink from 15 to 20 years before they start seeing impacts on their body. For women, it's 7 to 10. It's half. And so that's why, again, it's really important to get them connected. However, one of the areas, it's hard to get a GP. And I'm sure that's probably common for a lot of areas. The other issue for a lot of the women we see, they don't always see doctors because, again, I'll touch on the trauma piece, is they're terrified. And having significant and complex trauma histories makes it a bit of a barrier for them to even access doctors. And so finding physicians that are really safe and understanding of the trauma is really important. I've had women that are absolutely terrified because they're worried that someone's going to touch them. I've had women never have a proper physical their whole adult life, and now they're in their 40s. And so it's really important to get them connected earlier if possible. The other one is dental hygiene. The other piece for the women that we see, again, if you're using, they will have some dental hygiene concerns. However, again, because of some of their trauma histories, going to the dentist for most of us isn't a pleasant experience. And it's quite terrifying to do that anyways. But for women that have, again, trauma histories, it's much harder for them to even access dentists. And if you just envision, if you're laying on the table with your mouth open and, you're having someone coming at you, it can trigger a lot of flashbacks for them. And so that's part of the reason why they are absolutely terrified to even go to the dentist. And so, again, finding dentists that are very supportive and understanding and are trauma-informed is important. I know in Edmonton we have some that are really, really good. For example, I have a lady I work with, she has to be put under every time she does see the dentist because her trauma symptoms are so severe. And even though she's put under, they still have to restrain her, and she still reacts, even though she's under, because of her trauma is so significant. And so she needs to be restrained even when she sees the dentist. Relationship concerns. Roles, and I'll talk about the dual roles. So in regards to roles around family of origin, so the family they've grown up in, so they will have different roles within that family, and then once they become adults, the roles within the community and the using community, it's really important to recognize that that role may change. So they may have had, say, the lost child, for example, in their family of origin, or the scapegoat, and now they're using, and they're in a community that's embracing, and sometimes they'll call themselves the doctor, or the mom, or the counselor, or whatever that role has changed, and there's a lot of status when it comes to that. And so when we're asking the women that we're working with to quit using, sometimes it can be a huge challenge to get them to separate from the people in the community. I find that's, besides the family, if they've had family issues around their substance use and other family members also use, I find the community part is the hardest part to get them to disconnect from, and to really recognize that there's multiple layers of why they stay connected. A lot of the times the women we work with use to be connected to others. Regardless if it's an unhealthy connection, it's still a connection. And so that is another reason why it's a challenge for them to quit, because they feel so connected to others when they're using, and that's part of the reason why they use. It's not uncommon for women to have partners who also use. We've done some studies, and one of the stats is 80% of men that go into treatment keep their partners. 80% of women that go into treatment lose their partners. And so that says a couple of things. One, a lot of times women have partners who also use, but also if you're asking a woman that you're working with to quit using, you're not asking her just to quit. You're asking her to probably change every aspect of her life, which may be what needs to happen, but she may be ready to quit using, but she may not be ready to quit that relationship. And so we need to make sure that we're working with her wherever she is with that, because that tends to be one of the reasons why it's very difficult for her to quit using. The other piece to that is, for example, if she does have children and she may have some services connected, sometimes we segregate them and we keep the services separate. And sometimes we do a lot of work with her, and maybe we're not doing as much work with her partner. And it's really important to be, again, very holistic in our practice. Yes, we need to have separate plans, but we have to also make sure we're connecting everybody and having them together when we're working with them, and having everybody at the table when we do work with them. Because again, her use is so interconnected with her partner's use. And if we're asking her to get clean and sober, but we're not asking her partner to get clean and sober, the chances of her going into recovery are a lot less. So it's really important to include the partner as well. The other piece is when you go back into their history of when they first started using, majority of the times you'll find out they started using either by a partner or a family member. So somebody that they've been very, very close to. Not uncommon for them to be introduced to substances at a very, very young age. If it had been a family member, 4, 5, 6, 8, 9. If you ask them the first time they got drunk or even had a blackout, they'll tell you 10, 11, 12, very, very young. And again, it's usually from a partner or a family member. And so, and the other piece to that is it's not uncommon, and this isn't for everybody, I don't want to blanket it, but it's not uncommon that they have significant addiction issues within their family of origin as well, for the women that we work with. Her experience of violence. During the Myths and Facts, I talked about Health Canada had a stat of 85% of women that enter addiction treatment have a history of physical, emotional, sexual abuse. With my caseload, and there's been lots of other studies that have been done where some of the studies, it's about 90 to 95% of women entering addiction treatment have a history of physical, emotional, sexual abuse for my caseload. And my colleagues that work in the same program that I do, it's 100%. And it's multiple times. And and from a variety of sources and a variety of areas. And so it's really important to recognize how that also plays an impact. When I had the earlier slide around the relationship model, and we touched on a bit about the traditional theories, and that slide had women used to medicate and to connect as well as to numb out some of their feelings. It's really important. I usually find women that we work with tend to be using, and it's a symptom of something else that's been going on. And so it's usually to medicate or to numb out or to cope with something that's going on. And so a lot of times they are potentially currently in an abusive relationship or had experienced abusive relationships. And so a lot of times they're using to cope with that. I had a lady, for example, where I had a lady I was working with who she got beat up very, very severely, and she was prescribed opiates. And when she was prescribed opiates and she was on quite a high dose, she got beat up again. And she said that it didn't hurt as much. I was able to disconnect more. So that started her using opiates all the time and trying to be as high as possible. So when she did get beat, she could disconnect from the beating. The other part was she had so much anxiety because if things weren't put away properly, she was always walking on eggshells. And so she went to her doctor, said she has lots of anxiety. She didn't explain what the anxiety was about. She just said she had a lot of anxiety. So she was also put on benzodiazepines. And so in combination of the two medications, she felt like she could cope with the relationship a little bit better. And that was like a 30-year addiction to prescription pills that started for her. And that, again, isn't uncommon. A lot of the women may be using because maybe he might not get so mad at me, and so maybe I can use so that I can mitigate some of that violence that's going on in the family. Or, you know, there's a variety of different reasons. And so a lot of times, again, the women we work with are using to cope with or to deal with something else that's going on. Usually when you peel that onion down, there's something else going on for them. And usually something significant, a loss, violence, trauma, so something quite significant for them. Another area that's really important to look at that's unique for women who are using is their experience of mental health concerns. With depression, as well as the other diagnosis, it's very common for women to have concurrent disorders. And so when we work with them, we need to make sure we're integrated and we're working on both at the same time. Because if you look at someone who might be using, but their mental health is really unstable and they're having a really hard time coping with that, and she might not be able to stay clean long enough because of the other things that are going on. So we really need to look at both of them. I know some of the questions have been, well, we can't tell what came first or if it's the substance use, because substance use, when people are using, can mimic mental health symptoms. I always say, regardless of the cause, we still treat the symptoms. And then we'll kind of figure it out because we still have to stabilize what's going on. So it's really important that we work on that very holistically. The stats are quite large in regards to the concurrent disorders. And so a lot of the women we work with do also have the concurrent piece, which is bipolar, schizophrenia, manic depression, those kind of things. A lot of psychosis. We see a lot of psychosis, and that could be drug-induced. And so it's really important to get the support. Was there a question?
Yes. Kirsty, I wonder if you could just comment on the frequency with which adverse child events or adverse childhood experiences show up in the women that you've described as having currently abusive relationships.
Right. So the question is the relationship with adverse childhood experiences in current abusive relationships. Correct. Would that be for their children or for them when they were children?
For them when they were children.
You know, there's been, like the ACE screening, when you do a lot of the ACE screening, which is the adverse childhood evaluation, I think it's called. Events, sorry. When I do the trauma, I have some slides on that, and it talks about their experience. They score quite highly when you do that tool, and the 10 questions on it. a majority of the women we work with score quite highly on that, actually. And that talks about their experiences of violence as a child or their exposure to different traumatic events as a child. And so they do tend to score quite highly. The flip side of that is they also talk about if a man's, and there's 10 questions, and if a man scores 6 of the 10, he's 4,600 times more likely to be injection drug user. Huge stat. So even for men, the difference. And so his risk of becoming an injection drug user is 4,600 times more likely for him if he scores 6 or more on that scale versus someone that scores less than that. So quite significant. When I do the trauma and addiction piece, I can bring that slide in regards to the ACE, just to kind of give you some more background if people are interested in that as well. And so in regards to the other mental health pieces, what I tend to do is I make sure that I refer women to we have psychiatrists at our site. We're quite lucky that we have a few psychiatrists that we're able to work quite closely with. And so that's what I do, and I'll refer them to them. The flip side of that, and I'll touch on it, is if you're working with someone who's pregnant and say she's on psychiatric medications, what ends up happening is a lot of times they end up getting taken off that medication because she is pregnant. And what I always talk about, it's really, really important that she continues to see the prescribing physician, whether it is a GP or a psychiatrist, because things can change. And so she still needs to be monitored and supported. And what they say, one, there can be risk to the fetus, and that's why they're taken off. But also, the pregnancy, for whatever reason, tends to kind of ease things up a bit and stabilize some of the mood for them. But it's really important that they get the support and they continue to see the doctor during their pregnancy. The other piece that's really important for that too is a lot of the women we work with are very high risk for having postpartum depression. And I can just throw out a question to you guys. Why do you think the women we work with don't get screened for postpartum? They fall through the cracks. They don't actually get the screening done for them. And so the reason why it's important for us to be a little bit more assertive to get that support is because, again, it's not uncommon for the women we work with to have their children apprehended. The screening happens when they get their immunizations at the public health centers. And so the women we work with aren't always the ones that take them for the immunizations. And so what happens is they never get the screening done. And because of the past traumas, because of everything that's going on for them, they are very, very high risk for postpartum. And so really, really important that we make sure that we support them after the pregnancy. And what I tend to do is I'll get them connected, and then right before their delivery date and right after, I make sure they have a few appointments, because we don't always can guarantee when they're going to deliver, but I make sure they still have appointments very close to after delivery and just before delivery, and then they can continue seeing their psychiatrist quite often early on, because again, symptoms can flare up early, and sometimes it takes a while. And so we need to make sure we're getting that support for them. And again, the postpartum that the women that we see also experience isn't necessarily just the baby blues. We're seeing the extreme part of that where they get the psychosis. And so it's really important that we get them that support, because it tends to be more of the severe end of the postpartum depression and not just the baby blues. Poverty and social isolation. This is another one that's quite significant, a barrier or an impact for the women that we work with. Women tend to be the primary caregivers of the family, and so trying to find safe, affordable housing is very challenging. I'm sure that can be anywhere. In Edmonton, I think the housing market is, for rent right now, it's less than 1%. And so it's actually almost impossible to find housing in Edmonton. I'm sure that's probably very similar for other people in different communities. And in regards to women and children, say you're looking for housing for them or supported housing, there's lots of barriers and lots of gaps. If there was anything that, we could wave our magic wand and get some support, I think that's one of the biggest barriers is housing, supported housing for women and children. There's just not a lot of options for them. And so again, a lot of times because they are their primary caregiver, they tend to have a challenge in regards to living in poverty and being very isolated as well. And and I'll go back into societal pieces in regards to, sometimes we talk about how far we've come into the gender equality, but I think it was last year there was a stat that for the same job in Canada, for women, we make about 73 cents to the dollar that men make. We still make and earn less than men for the same jobs. And so there's still that incongruence in regards to pay scales. The other piece too is, we had the feminist movement and we had all these movements which we really needed to have happen. However, one of the things that we're still working on is we're the primary caregivers. So we take care of the families full-time, but we also have full-time jobs. So we're actually being stretched in a lot more ways than we ever have been as well. And so just being aware of some of the pressures that a lot of the women we're seeing face as well. Body image and self-esteem. For the women we work with, again, when I talked about the mental health, very high correlation between mental health and addiction. The other piece that there's a very, very high correlation is between addiction and eating disorders. A lot of the women we see have eating disorders. One of our treatment centers here in Edmonton talks about how they tend to have to call people in to fix their plumbing often because women are purging so much in treatment that it's actually backing up the toilet systems. And so they have to have people coming in to fix their system so often. And so what we end up finding is once women try to go into recovery and they go into treatment, their eating disorder really flares up, but that's a piece we don't always recognize. And so it's important to have a conversation with them about their eating habits, if they may have an eating disorder, because they do directly intertwine. If you have someone that goes into recovery and she may be, say, 90 pounds because she's been using crack, and for a woman who's using crack, you can burn up to 16,000 calories a day using crack. And so when you look at someone that has an eating disorder, that's a huge reason why they continue to use, because they can burn, one, it suppresses their appetite, but they can burn a lot of calories in a day. And so when you ask them to quit using and they start to gain weight, it's very hard for them to do that. And so that's part of the reason why they end up relapsing. And that's why it's important for us when we're working with them to find out maybe they might have an eating disorder. They may not have defined it that way. They may not realize they might have one. But it's important to ask some of those questions. And some of the questions I've even asked is, did you eat today? And a lot of times they'll tell you yes, but then you ask them what they ate and they'll say, well, I just drank coffee today. Or I chewed on some meat and sucked the juice, but I spit the food out. Or they ate, but then you have to ask, did they keep it down? Because they purge. And so I make sure I have some of those questions for them, see what kind of support we can give for that piece as well, because chances of them going into recovery and staying clean and sober if they do have an eating disorder, and we're not working on the eating disorder as well, is going to be diminished. The other one is self-esteem. And I would say this for anyone that has addiction issues. Self-esteem is so greatly impacted. And when I talked about, so what's unique about women and their substance use, and I touched on guilt and shame, when there's been studies done, and one of the studies that Nancy Poole did was asking women what's the number one barrier for accessing treatment. And and a lot of times when we ask this question, when we do this training, usually the answer is childcare. That's what service providers say. But the actual number one barrier for women is their feelings of guilt and shame. And so self-esteem is so greatly impacted, and that piece is so important. And it's like right to their core. I almost use the analogy at times, and I think I did this with the values and attitudes I might have. It's almost at times it seems like their soul has been shattered. And it takes so long to put those kind of pieces back together again. And the hurt and the pain that they experience because of all the other things that are going on for them, that one's huge. And it's really important to come from a strength-based model when we work with them. And strength-based as well as an empowerment model, just because of how impacted their self-esteem is. And again, sometimes with the best intentions, we can actually create more issues around their guilt and shame. For example, I had a lady I was working with, and again, like I said, with the best of intentions, we want her to access support. And sometimes, and I've heard this said to women, is, you know, there's more than you here you need to think about if she's pregnant. And I always say, and I mean, I've had that happen to women I've worked with, and what ends up happening, they're gone. We don't see them again. And I always say, that's the reason why they're here. Of course they care. I've never ever met a woman who does not care about her child. I've not met one woman. They always care. And I always say, you know, when they're pregnant, it's actually a window of opportunity. But pregnancy doesn't cure addiction. And so as much as it's a window of opportunity, and yes, majority of the women quit or cut down, it still doesn't change the fact that they have addiction, and so sometimes it's very difficult for them with the best of intentions, with the hope of quitting. And again, it feeds into a lot of that guilt and shame. And so that's one area we could do a lot of good work with them. So what might prevent a woman from seeking help? So I'll touch on their personal barriers, interpersonal barriers, structural program barriers. So the first one is personal. Again, I don't mean to harp on it, but I just, again, it's still that shame and guilt is the number one reason why they don't come. And I always say the biggest strength that the women we work with have, not the only, but one of the biggest strengths that they have is they read people. That's how they stay safe, and that's how they stay, and so they can walk into a room and they can figure out who's going to be supportive, who might be judgmental. And so it's even if we might not be the best person to work with them, it's about finding the right people, because we can really impact that shame and guilt and send them out the door quite easily. So it's important that we're quite cognizant and gentle when it comes to that. More immediate life issues, and that's related to when I talked about women being the primary caregivers. A lot of times they're pulled out of treatment. For example, say they're doing outpatient intensive programming and their children's sick and they have no one else to watch them, so they get pulled out of programming, and then they have to quit the program because they have to take care of the children. Legal issues, something might happen with a family member or their partner, and a lot of times that ends up really interfering with their ability to go into treatment. The other piece is with women that have children and they go into residential treatment. They may not have a safe place for their children, and trying to find someone to take care of their kids for 4 to 6 weeks, maybe longer, can be a big challenge for them if they're looking at going into residential treatment. And so that one's a really difficult place. Even I've actually had difficulties for women even going into, let alone like detox, which could be 7 days. And so for them, just finding safe places for their children to take care of their children can be a challenge. The other one is perceived expectation of abstinence in treatment. Sometimes when we talk about treatment, we tend to jump to residential, and we see that as the only treatment option. But there's treatment's a continuum, and that means from one-to-one counseling, group, psychoed, a little bit more intensive programming that could be on an outpatient basis, up to residential. And residential, yes, there's expectation of abstinence, but for a lot of the other programs, they don't have to be abstinent to access, and they can still get support. And so sometimes women feel, if I have to be clean, I can't even imagine being clean and sober, so if I have to be clean and sober, there's no way I can go to treatment. And so just having a conversation that treatment isn't just residential, there's a lot of other supports that they can get in place, even if they might be still using. The other piece to that is, I always say your best relapse prevention plan is what they do after they leave residential programming. And so they really need a good foundation for what supports they have in place for when they leave residential. And so I always say, make sure you get them connected to an outpatient service anyways. multiple layers of interrelated issues, and we've touched on that quite a bit already. So that could be you have a partner who's also using. It could be an abusive relationship. She might have some health concerns. She might have some issues with her liver or her kidneys, or she may have diabetes now and it's not stabilized. Things going on with the children. So there's so many multiple issues that she needs to, not that she needs to, but so many multiple issues that can impact her ability to access treatment and stay engaged, and so that can really pull her out of that. And again, addiction to the street, I touched on that a little bit when I talked about the roles. And I find that's probably the one thing that they have the hardest time leaving is that community setting, and they can have addiction to that, to the lifestyle. And so recognizing how difficult it is for them to leave. Some of the other challenges that they might have to quitting is peer pressure. You may have also noticed sometimes when women go into treatment, and this could be for anybody, men and women, they'll say, I've never had so many free drugs, or people coming to my house saying, come, let's go party. And it happens when I go into recovery because people keep pulling them back, and there's a lot of peer pressure for them. When they go into recovery, what ends up happening is most of their social circle are people who also use. And so there's not a lot of support for them when they go into treatment. I talked about their health. Fear of success. I've had women say, it would be, if I gained, I'll say stable housing, I've been in clean and sober for a little while, and I lost it all, I can't even imagine losing it. So they fear succeeding because the hammer's always dropped for them. And so they fear losing all of that, and that really can impact their ability to stay clean and sober. And sometimes that's when that self-sabotage comes into place. And fear of withdrawal. Fear of withdrawal is really significant, particularly if you're looking at someone who's using opiates or benzodiazepines, the anti-anxiety medications. Withdrawal is awful. It is, if you can imagine, if you could pick the day that you could have the worst flu you've ever had, and it's at least 10 days, and it's coming out of both ends, so you're vomiting, you have diarrhea, even your toenails hurt, and your hair hurts from the top to the bottom, every part of you hurts, you have muscle aches, spasms, you may have seizures, because people coming off of the benzodiazepines are at risk of having seizures. It's terrifying. And it's very challenging for people to come off. And so, again, that's another area that is a reason why people can't quit using, because of that fear of withdrawal is so severe. Lack of knowledge of resources. I've been in the field for a little while, and I still can't keep up with what's out there. And there is a lot of support and a lot of programs, but it's hard to keep up with what's available for them. And so maybe they might not know what is available, and sometimes it's building that web of support on our end and making those connections. I always say, the work that we do, we can't do in isolation. There's so many areas that they need support, and if they only have one support worker, we're at the end of the day could be doing them a disservice, because then they don't have other options. And so it's really important to build that web of support, and so they have other options for them. Lack of available resources. Again, I touched on one of the biggest barriers is for women and children. One of the barriers can be gender-specific treatment. There's options out there for sure, but there's not as many options that's available. Even in the co-ed treatment centers, men always have twice the amount of beds than women. Even in detox centers, men have twice the amount of beds than women do. And so there's not always the resources, and with the resources we have, at times it tends to be quite a long waiting list. So that can be a barrier, because sometimes there's that window of opportunity and it's quite short, and then we lose them for a bit. So that can be a challenge. Too much pressure. And that can be from themselves. A lot of times they'll want to do, they want to get everything done, and it's like they have 5 different programs they want to get connected to. They want to start going back to school, going back to work, and they put way too much pressure on themselves, and then they get overwhelmed and it just kind of blows up. And on the flip side of that, I think sometimes we can put too much pressure on them as well. Again, for some of the women, for example, let's say they do have a bunch of workers involved. Say they have, an addiction counselor, a family support worker, an outreach worker, maybe they have children's services, and so they could have a lot of different plans, and they just don't know which plan they need to listen to. And so sometimes on our end, we can just put a lot of pressure on them. And so I always encourage, I do a lot of case conferencing and bringing everybody to the table so we can work from one plan instead of having 5 different ones, so that it's much more feasible for her. And she also has a voice at that table and can have us all on the same page as well. And the addiction itself. The addiction itself can be the biggest barrier, and just that whole process around that. Some of the interpersonal barriers that women face is fear of losing their children. That's a huge one. Sometimes they fear if they access services that if they're pregnant, their child will be apprehended when they give birth, or if they have other children at home, that their children will be apprehended, and they're terrified of that. And so sometimes that can be a big barrier for them. And so that's one of the reasons why one of the things that I do in Edmonton, we have some prenatal docs that really understand addiction. They're fabulous, and they are able to support them before they even deliver. And what they do is they'll do tours in the hospital with them. They'll get them to meet the social workers as well, so that that anxiety and that fear can be lessened quite a bit. And what I also do is, for the women I work with, I get them to actually, right before they deliver, they always get walking papers that they're supposed to bring into the hospital with them. I also get them to put in that all the programs that they've done, the dates, their workers' names and phone numbers, and so that if they do have someone come talk to them, they have all the information with them at the time, because it can be quite overwhelming when you go into hospital, you're delivering, and then you have a bunch of people coming in that you don't know, and you have nurses, you have doctors, and then you have the social worker, and then you might have children's services come in and have a conversation, and it can be quite overwhelming. And so sometimes what they might forget some of the detailed information. And so I always call it like their little resume, and that they put that in place with their papers that they have to take into the hospital, so that they have the information that they can give, so it can reduce some of that fear for them. Lack of low cost and reliable childcare. If they are accessing supports, say they are going into treatment, they are taking programming, just finding a safe place that they can afford for the children to be while they're taking programming can be a challenge. Lack of partner or family support, we've touched on that quite a bit. Sometimes, and it's not uncommon even with the family members to say, and it's happened so many times where I've had women who've gone into recovery and they've had a parent say to them, "Why are you even bothering? All you do is use anyways, so what's the point? You're gonna relapse." Or, here, you've been clean a little while, here's some drugs, and kind of pulls them back. And so sometimes the ones that we feel are the closest to us are the ones that are keeping us stuck where we are. Lack of education and job skills. Again, because of the addiction, a lot of them haven't had work or employment, and if they have had work and employment, they haven't had stable work and employment because the addiction's impacted that. Again, with the education piece, you'll see a lot of the women, if they've had family of origin addictions in the family, they've quit school at a young age. Sometimes it's to take care of their other siblings. Not uncommon for some of the women I work with to have just elementary. They've gone up to elementary because they've had to stay home and take care of the kids at a very young age and become parentified, and so they haven't gone back to school. Or if they've gone into junior high, it's about grade 8 or grade 9, and so that piece is can be a definite barrier for them. But it's also an area for once they go into recovery, some of the goals that they really want to work on as well. Outstanding criminal justice issues. A lot of the women we see do have legal issues, And if they have warrants, they can't go to residential programming. And so sometimes having the outstanding, or if they have court dates coming up, residential programs won't take them because they'll tell them to deal with the court stuff first, and then you can come into our program. And it's a huge barrier for them because, you know, they don't know if they turn themselves in for the warrants, if they're going to be put in jail for a while. And so a lot of times that can be a huge barrier for them to access some of the services because of the justice issues. And then the power imbalance. And that in regards to us as workers. And no matter how much we try and make sure we kind of get as close as possible, there's always going to be that power imbalance. And to recognize and be cognizant of that. And when I do the trauma and addiction, in December, I'll talk about trauma reenactment and how a lot of the women that we work with that have trauma histories and some of the ways they reenact their trauma. And this is one of the ways that sometimes if we're trying to we're not cognizant of the power imbalance and we don't always recognize that, sometimes unfortunately we reenact some of their trauma. And so I'll talk about that a bit in December, but I think it's really important to recognize that piece and why they might not come in. A lot of times they fear coming in, they don't trust us, and trust takes such a long time. And building that rapport and safe place for them is really, sometimes can take a long time. Lack of flexible services. And that just means, and again, our programs do have mandates, absolutely, but sometimes programs can be a box, and we try and get everybody to fit into that box. And because of that, that eliminates the ability to support a lot of the women. And so when there's a lack of flexible services where there's more gray, and maybe if we're not always asking, how do I keep her engaged in programming versus, okay, who's not a fit? And sometimes we'll use the language inappropriate, or this isn't the right program for them. And if we use that language, we're always trying to find ways to eliminate people into getting support. And I think what we need to do is reframe it and start asking the question, how do I keep her engaged? How do I get her to stay engaged into treatment and becoming a little bit more flexible? Costs associated with treatment. Here, treatment is $40 a day. For women that might be on income support, they can definitely, most of the time, get their treatment costs paid for. If they have treaty status, they can get their treatment paid for. If they are in that area of working poor, so they're working but they're maybe making minimum wage or just over minimum wage, the opportunity for them to access residential treatment probably won't happen because there's absolutely no way they can pay for treatment. One, because they can't get on income support because they're already working, and there's no way they can afford going into residential programming because of the cost. And so that can be actually quite a huge barrier for them. Or say you have someone that's looking at getting onto the methadone maintenance program and she doesn't have health care, or she isn't on assistance. That can also be a barrier for her to access treatment. So the other one in regards to the structural and program barriers is lack of community capacity. I think sometimes we work in silos quite often, and we do our day-to-day work, but it's really, really important that we work together as a team. And I always say that the partners that I work with in the community at the different agencies are my team. That's who I work with. And I think it's essential that we work together as a team. The other piece with that is if we're so disconnected, we're only working on pieces of the pie. We're not able to work on the whole pie. And so if we only work on parts of what's going on for her, we're missing a huge chunk. I can't imagine doing the work I do without being connected to the psychiatrist, without being connected to her family support worker, without being connected to even her children's services worker, and even knowing what's on her plan so I can support her through that. I think it's really important that we build capacity with us. The other thing is, if we're looking at doing referrals and we already have that relationship with the women that we work with, it's so much easier to refer to a person versus an agency. Again, when I talked about trust and safety is one of a big barrier initially when we're working with them, but we've already established that relationship and we say, okay, hey, I'm going to refer you to this person. It actually helps with them being able to access that site versus saying, okay, go to this agency and get connected. It's very difficult to do that. And so it just makes things much more seamless and it reduces a lot of those barriers. And lack of gender-specific treatment. Like I mentioned already, there is definitely options, but there's not enough options. I know for some of our programming, for example, I'll use our day program, we always have way more women accessing our day program than men. We have a lot more women accessing services now. I know traditionally men was much more represented within addiction services. It's not the case as such anymore, but the thing is a lot of the programs haven't made more room for women. They still have the same amount of beds for women that they had 20 years ago. And so what ends up happening is women end up waiting a lot longer for treatment. Say they're going to go into a residential program, they end up waiting a lot longer than men do just because there's less opportunities for them. And again, there's not much options in regards to gender-specific programming for women. And before I move on really quick, I think, sometimes people are like, well, why would it make a difference? And they've done research in regards to gender-specific versus mixed groups. And the research has shown that men do really well in mixed groups. Women might not share as much within a mixed setting. They tend to do more of the caregiving within that group. But if you have a women-specific group, they tend to stay longer, be more engaged, and share more deeply. And so that's why, a lot more of the research that's coming out now around gender-specific tends to be more important in regards to finding ways we can get them that support, because they tend to be more engaged and do a lot more deeper work if it's a gender-specific group versus a mixed group. So the next part I'm going to talk about is maybe some more of the interventions. And so the first one, when we're talking to women that are that might be using, it's really important how we introduce the discussion and the approach you take. And like this says, the approach you take is one of the strongest indicators whether a woman will change. And when I talked about the number one reason why women don't access treatment is because of her feelings of guilt and shame, that you probably have heard the term therapeutic alliance. And I believe it's Scott Miller who says 80% of your outcomes when you're working with someone has to do with the therapeutic alliance, and it's up to 80%. It doesn't matter your therapeutic intervention, whether you do narrative therapy, solution-focused, CBT, whatever therapeutic intervention you use, the biggest indicator of having success is having that therapeutic alliance and if they feel connected to you. And so this is so important. I know some people are like, but I don't have a long time, depending on the programs we work in, some people are like, well, I don't get an opportunity to spend a lot of time with somebody. So how can I make a difference in somebody's life if I only get to know them for a couple of weeks? Or say I'm a nurse and I work in Emerge and I only get to talk to her for, that one time that she's come in. But I can guarantee you, regardless of the length of time that you spend with her, it is the approach that you take that makes the biggest impact. And I have so many women that come back and say, I wish I could go back and say thank you, because that person treated me with dignity and respect. And I have never forgotten that, and it stayed with me. And that could be somebody that's only spent a half an hour with them, but they never forgot the impact of how they were treated. When I talk about being trauma-informed, and we talk about, some of the principles around how to be trauma-informed, even from the moment they walk into the building, and I'll have so many women that say, I just wish someone would just say hi and treat me without, for example, kind of stumbling on my words here just because I was debating on whether I should give the example, but I'll give an example where I have a lady that has been accessing a service for quite a long time, and whenever she comes in, they just look at, this is what they do. Name, take a seat. They don't even look at her. They always say, they don't even say, can I get your name? They just name, take a seat. And it just she sobs. She literally sobs because she already feels like she has a scarlet letter and everybody can see what's gone on in her life. Like, it's all transparent. Even though she's not, she just feels that way. And she's like, I just wish they'd say hi. I know they know who I am. I wish they'd just say hi in my first name. And they just don't even recognize me as a human being. And I think, you know, from the moment they walk into the building, that piece can play the biggest indicator whether she'll stay or not. If she has a bad reception, as soon as she walks in the building, the chances of her coming back, probably not. It's going to be so much more challenging for her. Before I move on to the next slide, with the same research, when we asked what's the biggest barrier for women accessing treatment, within that same research, what's the number one reason why you came to treatment? And it's because a service provider treated them with respect. That's the number one reason why women said they access services, is because they were treated with respect from a service provider. And so, again, it just shows the power of how we work with women. The next one I'm going to talk about before we talk about other areas is it hard? And I know, given it's a webinar and it's kind of hard to be a bit more interactive this way, but I'll just throw it out there. Is it hard for you to talk about substance use? For some of us, for me, example, because I talk about addictions all the time, it's just a part of my assessments. People expect to come talk to me about that anyway, so it's not always a barrier. But I think sometimes it's important to ask ourselves, is it hard to talk about substances? And if it is, why is that? And just kind of reflecting on why it might be hard to even open that door and having a conversation. I've heard people say sometimes one of the reasons why they don't talk about it is because I worry they fear I might be judging them. Or if she tells me she's using and she's pregnant, what do I do then? Like, it's too much. Or maybe they've had personal experience personally with themselves or a family member or partner who have concerns around their substance use. And so maybe it's hard for me to talk about it because it might trigger my own stuff. And so just kind of having that conversation and finding out, is it a challenge? If it is, how come it might be for a challenge to talk about that? And what we find is sometimes it's about the approach you take as well in regards to this. And so instead of asking, do you abuse alcohol? Because that's latent with a judgment. Do you abuse alcohol? She'll probably say no. Particularly if she doesn't feel like she has a problem. But if you say, do you drink? Or even if she's pregnant, and sometimes, again, the guilt and shame, and she may not want to talk about, maybe she has drank in her pregnancy, but she has a lot of guilt and shame around that. Sometimes what I'll do is, did you drink before recognition of pregnancy? Because the answer might be different based on, did you drink during a pregnancy? Nope, I haven't drank. Did you drink before you found out you were pregnant? The answer might be different. And even with the substances, it's just, just about how we ask the question. I always say it's important to kind of roll it in with your overall assessment as just, so it becomes kind of second nature, just asking about substances as a part of that. If you are working with pregnant women, I also say to ask them more than once during their pregnancy because things change. And so, they might not be drinking when they first met you or early on in the pregnancy, but they may be drinking later on. And so it's important to have that conversation more than once. So regardless of how much or how little time we spend with her, our ability to be compassionate and understanding is the one thing she'll remember. And this is the bridge to effective relationship with her. And I know I've kind of harped on that around the therapeutic alliance, but I can't emphasize enough how important that piece is. Screening. When you are doing screening with her, not just to screen around alcohol and substances, it's important to screen for everything and to screen for her readiness for change. She, for example, and sometimes what I'll do is I'll split it up because a lot of the women I work with use a variety of different substances. And so she might be in action stage for her alcohol use, but she might be, in action is where she's ready to make the changes, but she might be pre-contemplative, and that's where I don't have a problem, kind of get off my back. I don't want to make changes for, say, she uses opiates. And so it's just important to kind of tease out her readiness for change on all the substances, as well as maybe some of the interpersonal stuff in regards to maybe her relationship. Some of the people that she's connected to, even her family members. And so it's really important to be very holistic when we're looking at screening. The other one is, I touched on screening more than once throughout her pregnancy, but then I also ask her about relapse prevention, and I come up with a really strong relapse prevention plan before she delivers, because again, pregnancy tends to be a window of opportunity, and again, a lot of them do cut down or quit during their pregnancy, but what ends up happening is they're at very high risk for relapsing right after delivery. And so I do a lot of relapse prevention prior to delivery. And a lot of times they'll say, no, I'm good, I'm not concerned, but it's always good to have some safety precautions put in place, because again, relapse tends to be quite high after delivery. And so yeah, that's another piece that's important to also recognize as well. So offering information. So asking her about her knowledge around the risks of substance use in pregnancy, asking her if she has any concerns. A lot of times she may not be able to have she may not have had the ability to have a conversation to work through some of the emotions related to her use and being pregnant. And so it's important to, work through and have her process what she feels about that. And again, getting her connected to prenatal care and physicians that are understanding around the substance use and how they can support her. The reason why it's important to get people that get it and understand it, because I know at the beginning I talked about misinformation and denial among those in position to help is one of the factors that are key issues for women. And for example, I'll give you a situation where I had a young lady that I was working with who had been using, and it was the first time she accessed support. She was going to prenatal care all the time, and she was in her 3rd trimester, and she was getting worried. She was worried about apprehension. She was worried about becoming a mom for the first time. She had a lot of different things going on for her, and she was worried that she'd relapse. And she was talking about it, and what ended up happening is her worker said, if your child's born alive, you're going to be lucky. And if your child's born alive, your baby probably won't live very long. Complete false information. That worker gave her horrendous, and it was misinformation. And I think it was a scare tactic. I think they thought if I scare her straight, that if I tell her this, she won't use, and then we'll be good. And the lady was doing the right thing. She was talking about her fear. She was talking about what her thoughts were, and she was working through it, and she was coming up with a plan. And what ended up happening for that lady is we never saw her again. She stopped going to prenatal. She stopped accessing services. She went and delivered. Baby was apprehended. Baby went permanent guardianship. We never saw her again. And that statement was very powerful, and part of it is she used early in pregnancy before she found out she was pregnant. Once she found out she was pregnant, she quit using, she went to programming, she got a lot of support. And with that statement saying, if you use, you're going to kill your baby, she thought she killed her baby. And, you know, and so it's important that we're cautious in the information. If you don't have the right information around effects, you don't give the information on effects. So we're cautious, but I think it's important to allow them to work through some of those emotions and supporting them through that, but also getting them connected to the right supports that have the right information that can support them through that. So exploring options for change. Different areas that we touch on is harm reduction, and then after harm reduction we talk about actual treatment, and then community support. Before I go into harm reduction, we've touched on a lot of different options that women can have for treatment. We've talked about outreach support, we've talked about prenatal care, outpatient one-to-one groups, maybe more intensive programming on an outpatient basis or residential. So those are a lot of options for her when she's in the action stage of change. And so she's ready to make those changes. But say you have someone that might be not ready to make those changes and is still actively using. So what do you do with them? And so someone that might be pre-contemplative or contemplative. And so that's why we start out with harm reduction. And so some of the principles of harm reduction is, you probably have heard a variety of different definitions. I think the standard is there's no universal definition of harm reduction. But what it is, it's a set of strategies to reduce negative consequences of certain behaviors. It meets people where they're at. It reflects individual and community needs, and it's non-coercive and non-judgmental. The goals are to reduce the risk related to alcohol, drugs, and tobacco, access prenatal care or overall health care, to eat well and stabilize their living situation. So all that really says is we look at the person we work with in a very holistic fashion, and it's almost like Maslow's hierarchy. And so we work on the basic needs, making sure the safety and security is taken care of. Then we're looking at the health, and then we're building up on that hierarchy of Maslow's hierarchy. And so we're just being very holistic in how we're working with them, and that we're just building up on that. Sometimes when we talk about harm reduction, I think sometimes people say, well, I can't do harm reduction based on personal philosophy or agency philosophy. And sometimes they see harm reductions only doing syringe exchange. Or maybe I work for an agency that talks about birth control and condoms, and my agency doesn't support that. But it's also to be aware, again, just like the treatment continuum, within harm reduction, there's also a continuum of interventions that we can use that are still supportive of where the client's at, because we really cannot be 30 steps ahead of them. If we're 30 steps ahead of them, we're putting way too much pressure on them. We're not in having that therapeutic alliance, because our expectations are way too far in advance for them. And then we start using terms of inappropriate, non-compliant, resistant to treatment, and it's not anything to do with the client. It has everything to do with the plan that we have. We're just in a different place than they are. So it's about looking at, okay, what can I do based on my agency's philosophy and also working within the harm reduction. So one could be teaching safer substance use techniques. For example, say you do have someone that does inject drugs, and half of the addiction actually is the injection drug use, not just the drugs itself. And for a lot of them, they have a ritual when they're using. And so for some of them, they might lick the needle before they inject, or they might lick their arm. Say they're going to inject in their arms, they might lick their arm and then inject. And we know we have lots of bacteria in our mouth, and that puts them at very high risk for infection. And so even if we can kind of break it down and say, okay, what is the ritual? How do you inject? And if we can eliminate some things, it can reduce them from having infections and abscesses. Hypothetically, let's say, well, chances of them getting abscesses are pretty high anyways. Say they do get an abscess. A lot of times, again, because they fear doctors, they don't have a doctor. they end up doctoring themselves for quite a long time and then they get very, very sick, and that's where you see them maybe cycling in and out of emergency more often for a variety of different reasons. But that's when they get more of the blood infection because it spreads so much. And so what I do is I'll have them come in and I'll get a pen. I was just looking for a pen. There's no pen here. But I'll get a pen and say there are abscesses on their arm. I'll draw a circle around where the abscess is, and then I get them to come back. And it's a visual to show that it's spread. Because a lot of times if they don't have the visual and you say, oh, it looks worse, they're like, no, actually it's better. It's not worse. It's okay. But if you have that mark and they come back and you see that it's spread, it actually is a visual for them to say, oh, maybe I need to go get it seen before it gets so severe that they end up hospitalized because of the infection. Sometimes if they're another option in regards to harm reduction is getting them connected to methadone maintenance and having that support that way. Again, because of the fear of withdrawal, and a lot of times it's very difficult to come off opiates, methadone maintenance is definitely an option for them. For pregnant women, they have priority access to get on to the methadone programs. Here, anyways, I don't know all over. I would suspect probably they would have priority access, but for sure here we have that. The reason why methadone is and that's actually if someone who's not pregnant and using, it tends to be one of the last options that we give to them for the methadone maintenance just because of the commitment for it. And we do try to get them to try a variety of ways of quitting before they get onto that program because, again, it's a huge commitment. And once you get on, you have to actually be on it for quite a long time. But when you have a pregnant woman who comes in, the actual recommendation is that she goes on to the methadone maintenance program. One, if she quits or goes into withdrawal, it puts her and baby at risk. And so she's at very high risk for miscarriage or premature labor. It's a stable dose, so she gets a stable dose once a day. A lot of times when people are using prescription medications, their dose isn't always stable, and so some days they're getting higher doses, some days they're getting less. And so she's at risk of ODing, she's at risk, again, the pregnancy's at risk, and so there's always that up and down, and so getting onto the methadone kind of stabilizes everything that's going on for them, and it can stabilize even their eating, their living, their health situation, those kind of things. And so that's why the recommendation is methadone for pregnant women. I always talk to the clients about, because again, a lot of times they use a variety of different substances. So I always make sure I talk to them about the interactions and the importance of OD management. In Edmonton, we do have a program through Streetworks that they have peer support that will teach people how to help prevent ODs. I think that's across Canada. They have different areas where they can help prevent ODs as well, but also to take into consideration the other substances that aren't opiates. So that's the alcohol, the cocaine, sometimes they're using ketamine or GHB, ecstasy, and sometimes with all that combination, they can be at risk. When I talked about the health factors, I didn't touch around tolerance. And so for people who are using, they build tolerance. So, when you have your first drink, you usually feel a bit of a buzz. Your very first drink ever, you'll feel the effects. After time, you can drink more and more before you start feeling the effects. So you're building your tolerance up. For women, because of their impacts on their health, their liver, their kidneys, their heart, and it's much sooner, what ends up happening is they get reverse tolerance much quicker than men do. And so reverse tolerance means they can't drink as much as they used to. Before they could go out, drink a 2.6 to a 40-pounder, and that's not uncommon. I have a lot of women that will drink a 2.6 to a 40-pounder and be able to do that. Now they go out and they drink a Mickey up to a 2.6, they black out, they can't remember, and it puts them at much higher risk of ODing because that means they're having health issues related to their substances. And you'll hear women say, Jane, she went and used and I don't understand, and then they come into this, she must have been murdered because she didn't use very much and she OD'd. I don't understand how she could have OD'd. she's been around a long time and she used less than I've ever seen her. And what ends up happening is their body just can't tolerate the substances anymore because the effects have impacted their organs. And so, again, talking to them about reverse tolerance, if you're starting to notice that they're not using as much and they're getting very intoxicated very quickly, or they're having much more blackouts, getting them connected to a doctor to get that checked out for them, getting their liver enzymes checked, and making sure that their health is taken care of, but also talking to them the risk of ODing as well. Sometimes people say I've had to change the way I've used and, kind of wean myself off. So I was injecting, now I smoke, now I snort, now I quit. Sometimes they have to change the method of use before they can quit. They have to kind of wean themselves off or taper themselves. Modifying their substance use, so sometimes people will use various substances to kind of come off. The other part that I'll touch on that's really, really important, and I would even say this is for somebody who's also gone into recovery, making related behavior safe. Because a lot of times they'll end up quit using the substances, but sometimes they're still active in a lot of the behaviors that they had prior to even using or while they were using. And it's so important that we talk to them about making that safe for them. And again, looking at all those pieces. And for example, I have a lot of women that are sexually exploited that I work with. And so talking about how to make that safe for them if they're still actively working. Some are doing chat lines. Again, when I talked about one of the reasons why they use is to make connections, and they feel so isolated and lonely and they just want to connect and have that connection to somebody. Even if it's this push-pull thing, like I want to pull them close and I'm going to push them away. I want to pull them close and push them away. At least they still have that connection. And so a lot of times what they end up doing is doing the chat lines. A lot of women are on the chat lines and meeting people anonymously and, becoming friends or trying to find a relationship, and it's not necessarily safe. So a lot of times they'll bring them back to their homes. And so talking to them about the risk of bringing people home with them that they don't know, or giving their address out to people that they don't know, or, if they are working, to make sure they work in pairs. And if they can't work in pairs, if they leave, they text the license plate number of the person that they're leaving with. So just making sure everything that's going on in their life is safe. And asking them what safety means, because safety means different things to different people. And so sometimes we might jump to safety means their personal relationship. And so we'll come up with a safety plan based on the violent relationship they're in. But we're not doing safety plans for other things that are going on in their life. So it's important to make sure we do a safety plan in relation to their partner if there's violence in it, but also safety plans in place for all areas of their life. And sexual health. And again, for some of the women I have, they've never had proper sexual health teaching. And so for them, having the opportunity to even understand the parts of their body and what that means and how it works, and having good sexual health support is important as well. So what are the basic tenets of harm reduction? One, it recognizes the dignity of the person you're working with. Maximizes social and health assistance. It recognizes the right for care. And I'll touch on that one a little bit more, just because sometimes I have found that people that have substance use concerns ends up being refused services because they have addictions. And that I'm a strong, it's kind of, I guess it might be like a soapbox. So I'm a strong advocate. Regardless of what's going on for somebody, they always have right for care. They cannot be refused services. And I've seen lots of women refuse services because they have substance use concerns. And so, for example, I had a lady who was severely raped. Terrible, terrible rape. Her support worker and her went to get some health support, and she didn't want to call the police. She had warrants, and here's where the legal issues can also play an impact. So she had legal issues, and she didn't want to call the police because she had warrants out, and she was worried she'd get arrested. which wouldn't have happened, but that was one of her fears. That's why she said, I'm not calling the police. And they told her, if you don't call the police, which shouldn't have happened, but they said, if you don't call the police, we're not going to treat you. And she was escorted out. And I know you can't see me, but from her torso to the middle of her thighs, she was black. She had internal bleeding, and she was very sick, and she was refused service. And, she was considered drug seeking, even though she never asked for drugs. She was classified a frequent flyer because she's accessed medical support. Really unfortunate. And I know that's an extreme end of people being refused service. I can give you another example where I had a lady who was in a violent relationship, and she'd go to this agency every day, and she'd sit on the couch, and the agency said to her, at a meeting, they didn't say anything to her. At a meeting, they brought it up that she comes in every day and she has new bruises. And they said, you know what? We just stopped talking to her. We just let her come in. She sits there. We don't bother because she keeps going back. And so in a subtle way, they didn't actually say anything to her, but they're refusing service because they were frustrated that she was still in this violent relationship. And I just said to them, like, who do you think she would have accessed when she was ready to leave? It would have been them, but they've disconnected that relationship, so she has no one to ask to help her if she chooses to leave. And so, there's subtle ways we can refuse service all the way up to the extreme, and regardless of a situation for somebody, they have a right for care. Recognize the competency of people who use. I think sometimes people believe because someone might be actively using, they can't get support, or they can't do counseling, or they can't do programming. And the fact is, sometimes people need to get strong and get the support in place before they can actually quit. And they can go to counseling, they can go and get the support, they can take some groups or psychoeducational programs. And sometimes they just need, because if they've never learned how to self-soothe and to cope, and they use external ways to do that, and we ask them to take that away, but we've never taught them how to cope or self-soothe internally. How are they going to stay clean and sober? So we have to teach them how to actually cope and have the strategies in place. And so, but again, a lot of people are refused service. Oh, you have an addiction? Okay, go deal with that, and you can't come here. So expects flexible, accessible, non-judgmental care. Challenges misinterpretation and misinformation. Us as workers, we can be very strong advocates as well for people that might be using substances and have a variety of things going on, and being a support to them. And so for us as support workers, it's important that we're able to support the information that's out there that could be misinformation, and be able to challenge that as well. The other thing is, one of the concepts in regards to harm reduction, and it's important to recognize that it accepts that drug use is present. It probably will always be present. And so what do we do to minimize the harmful effects of that? And so that's another tenet of harm reduction, to recognize that it's probably always going to be there. We're not going to eliminate that. And so how do we minimize the harmful effects that could be out there? It also acknowledges that certain ways of doing drugs are safer than others. And it builds on the quality of life for person based on their perceptions. And this is, again, when we look at how we're going to come up with plans and interventions and support, that they are I always say it's like they're the captain of their ship, that they are there to guide us. We're there to support them, but they're the captain. They know what works for them. We can give them information and guide them, but they know what's going to work for them and what's best for them. And so it's important that when we look at treatment plans, we look at the treatment plan based on what they want. Again, we can be 30 feet ahead of them. We may want the white picket fence and all of this for them, and they may not want that at all. That's not something they've ever wanted. And so it's important that we accept what it is they do want as well. because it could differ from what our goals are for them. And so we need to make sure that we build our plans based around what their needs are. And the last one is to empower the relationships that you have with the individuals that you work with. All right. So that's the end of that. Is there any questions? Whew. That was a mouthful.
Kirsty, there aren't any specific questions on the, from the virtual audience, but I have a question related to facilitators
Yes.
for treatment. So you listed a whole lot of barriers that really stand in the way of women receiving treatment. What are the most important facilitators? And you talked about the interpersonal relationship and the engagement piece. But even before that can happen, there need to be facilitators for women to even consider asking for help.
Right.
So do you know what those core facilitators are?
Like qualities or...
Both qualities and both kind of psychological qualities as well as environmental qualities.
Okay. I think that's a good question. I think I'll start with what I found really works. I always say what you give is what you get back. And so if you're compassionate, and I can say non-judgmental and throw it out there, and we always know that term, but truly being non-judgmental and accepting the person regardless of what their choices are and regardless if they want recovery or not. Just being there as a support, truly being non-judgmental, compassionate, and being able to be a strong advocate, but also knowing what's available, being really in tune to what's available for them. I find that works the best, but also having very good boundaries. I think when I talk about trauma reenactment next time, again, a lot of times the women we work with will reenact a lot of their traumas, and they'll play out in an adulthood. And what ends up happening is, for example, if you have a lady wanting to go into detox, and she's like, please, 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 can you get me cigarettes? I can't go to detox unless you get me cigarettes. But it's not your role. You can't buy them cigarettes, but you do it. And you tell her, don't tell anyone though. So what would that create? You're telling her to keep secrets, which mimics when they're children. You're giving her presents, which a lot of the women we see have been molested, but before they're even molested, they're groomed. And they're groomed with gifts. They're also told to keep secrets. And now you've changed the relationship you have with that person. And no matter what, it's altered. And I think really being a good support, but also making sure you always have your boundaries intact and modeling that is essential. If you lose that, you lose that relationship, because now it's, I'm special. We have the special relationship that other people don't have. If I end up relapsing, I can't tell you because I don't want you to be angry at me now. It just changes the whole dynamic of that relationship. And it's just one little thing. You bought them cigarettes and it reenacts. And a lot of times they do that. And so part of our job is to make sure we model to not do that. And so I think those qualities are essential in regards to, and you have to like women. I know that sounds silly, but I can't even tell you how many places I go and it's like, I don't want to do a women's group. It is so challenging to do a women's group. And I do women's group. I love doing women's groups. I think, you really have to have the passion and understanding, but also really truly understanding all the layers that impact and how interwoven all those layers are for women. If you just understand addiction, but don't understand all the other layers, we're missing a big piece. So I think you have to have all of those kind of qualities.
I have another question.
Yeah.
You talked about the gap that exists with respect to screening for postpartum depression in women who are using alcohol. And I wondered if you have any thoughts about the strategies that could address that gap. What could public health be doing differently, or how could that screening happen for all women in any event?
That's a really good question. I know with public health, we've had that conversation because a lot of times right after delivery, you'll have a community health nurse phone and want to come out and meet with mom and baby. Again, sometimes the women couch surfing. They don't have a permanent address, so it's hard to find them after they deliver. If an apprehension happens, not always, but majority of the time, they spiral quite rapidly, and we lose them for a little bit, and so it's hard to find them. But they usually have those specific workers that they still have that connection with, and I think it might be more on us to be able to make sure we're cognizant and have it in the forefront that we're bringing them in, because if we try and track them down from people that don't really know them, we're not going to find them. It has to be from the people that are connected, and being cognizant that that's something they're at very high risk for, and that we're able to get them in for that screening. But again, here's the barrier. Sometimes, depending on where they're getting the screen, we have to be cognizant about where we're getting the screening done as well, because again, sometimes because of the substance use, people won't screen them, which is unfortunate. So that's another gap.
Well,
Thank
thank
you.
you very much.
Thank you.
Thank you very much. No, just stay here for a
Okay.
second. Thank you very much for the informative presentation. I found the examples that you gave and the situations really helped to gain a better understanding of the barriers and the treatment and the key issues. So really appreciate that. Thank you.
Thank you.
For the audience, please note that evaluations will be mailed to you within the next 2 business days. Please ensure you sign the attendance sheet so that you can get these. And just a reminder, your feedback is really, really important as we move forward in planning. And please join us for our next presentation on December 18th. We really look forward to Kirsty returning for her presentation on trauma and addiction. Thank you.